Okay, this next little section is on AV heart blocks, or sometimes just called heart blocks. Um, there are four different types of heart blocks. You have your first degree, you have a second degree type 1, a second degree type 2, or a third degree heart block, or you also hear them second degree AV block, second degree AV block type 1, second degree AV block type 2, or third degree AV block. Um, you also hear them called Mobitz type 1 or Winkie-Bach for the second degree type 1. Um, and then that should have a T on the end. But there's just four different ones. And the first degree heart block, let me just bring that up. All that a first degree heart block consists of is it's typically just a PR interval that is greater than the norm. So if your normal PR interval is you have I'm sorry, I had to stop for a minute, but your PR interval is greater than 0.20. So if you count, from the beginning of the P wave over to the start of the QRS, or the beginning of the Q wave, you've got a bigger the PR interval in all these beats, okay, is greater than 0.20. So, what is going on is this is caused by delay in the conduction of an electrical impulse between the atria and the bundle of His. And this delay occurs when there's like a partial interruption or a slowing in the conduction of the electrical impulse through the AV junctional area. So, although um, they are eventually conducted to the ventricle, it's kind of slowed, right? But, really, first degree AV block is not a true block. It's just simply a delay. So the P wave occurs for every QRS, so we know there's no block, but they call it a block. Um, and it's just because the PR interval is always every P is always greater than 0.20. The size and the shape of both the P wave and the QRS are, sometimes may vary, but they are long. That PR interval is very long. Um, so, this is not an emergency, but it may indicate damage to the myocardium that has occurred. Um, and sometimes we look at blocks and we worry if a more serious dysrhythmia will occur. So we have, basically, your treatment's going to be, your causes could be, something that along the lines of CAD, rheumatic fever, hyperthyroidism, a vagal stimulation, some drugs that slow that conduction through the AV. You may, have a little bit too much on board, and it's usually asymptomatic. But like I said, it may be a precursor to a higher degree and an actual block. So we usually just check medications, and we continue to monitor this patient. You usually do not have any treatment. Now with the second degree block type 1, or Mobitz type 1, or Winkie-Bach, um, we do have a little bit of higher degree of a block. Um, Again, it's of course, if this is moved from a first degree to this, then we start to kind of get concerned. And we've already, if it's a new first degree, but if we started out with a new first degree Avery block, hopefully you've called the doctor already. But there's two types of sepsis, so we'll talk about the first type. And again, this is an actual, the block occurs, from when the impulse comes down the atria, and it's interrupted in the AV junction, so hence AV block. So, and so what happens is, as you see in this second degree type 1, is you see this progressive prolongation. You'll see the P wave. It'll be a 0.2. That's a 0.24 interval. Then it's a 0.40, and then it just there's a blocked QRS. So you just have a P wave and then no QRS. And see, it's kind of like you see it in that T. So it's a progressive prolongation, and then it doesn't conduct. So all you'll see is a P, and it didn't even hit the ventricle. So that's what you'll see. So if you see when you start to, and here's another one that occurred before, and then it didn't, a QRS didn't follow. So typically this is, a kind of a sign that something may be going to happen. Especially if it's a new occurrence. We want to be monitoring them. We want to make sure that we are checking, for drug toxicity. And if overall heart rate is bradycardic and the patient is stable, we just kind of observe them. But if the patient becomes medically unstable with this type of block, we're going to be looking at putting in a pacemaker, and if, we'll start with the transcutaneous or transvenous pacer, and then, until a permanent pacemaker is placed. So, but in the meantime, you can, consider giving them some atropine, to speed up the heart rate while you're waiting for this pacemaker. So, I know your book has more treatments besides that, but pretty much if this starts to get symptomatic, then you're going to be looking at a pacemaker, and then you can treat with atropine in between. Okay. So it's that progressive prolongation is what you're watching for. So these are the causes. It may be drug related, maybe to see some coronary artery disease or other diseases that slow AV conduction. But there's actual a block. Not like in first degree. It's just a slowing. This is an actual where you see there's a blocked beat here, and you'll see progressive prolongation of the PR interval. So, like I said, if it's symptomatic, we're going to give them some atropine and plan on a temporary pacemaker. If it's asymptomatic, you can monitor and then, just kind of have a temporary pacemaker on standby. It's you want to worry about hypotension, heart failure, and putting this patient into hypovolemic shock. So we want to monitor them. Okay, the next second degree heart block is a Mobitz type 2. And this is, also called second degree heart block type 2 or Mobitz type 2 or type 2 AV block. Anyway, so what you have going on here is that, and is a little bit, more serious to look at. And this occurs when there's an intermittent interruption in the electrical conduction system near or below the AV junction. And this interruption is not progressive like you saw in the Winky Bach, but it occurs suddenly and without warning. So it's just like you're just going to drop a beat. So you don't see a progressive prolongation of the PR interval. You just see a drop beat. And you see that because you'll see this P with no QRS following it. So typically, the rhythm strip shows a P wave for every QRS, and all the P waves are the same size and shape, but there's a Q, and a QRS will follow those P waves until that interruption, and then you see this P wave with no QRS. So, they can occur, in we call 2-to-1 block. So you might have two normal beats, and then you have a one drop beat, or you can have three P waves for every QRS complex. So you could have like three P waves and then a block, and then four P waves or a block. So I mean, I'm not gonna tell you to name that. Just be able to tell me, that this is a type 2 second degree type 2 block. And typically, if it is if this something like this is symptomatic, we're going to obviously treat it, and these patients, we really worry about them going into like what's the worst would be your third degree AV block, and so we're monitoring them. So the same situation, um, comes up here. So if they're symptomatic, what are we going to do? Are we going to we're going to give them some drugs, and then we're going to, sorry, let's start out with asymptomatic and they're stable. We're just going to kind of keep the pacemaker on standby, the the transcutaneous pacemaker, and then, so that if something does happen, that we do have the pacemaker at the bedside. But pretty much, you're going to assess the patient, And remember, this may become a lethal dysrhythmia. And if the patient is stable, you just observe them. And if the patient becomes unstable or shows signs of poor cardiac output, treatment needs to be started immediately. So that means you should have an IV already. You're going to make sure that their airway's fine. Have a 12 lead, which you probably have already gotten already. And if the overall heart rate is bradycardic, like I said, you're going to have a transcutaneous pacemaker. You're going to try and pace them or keep it at the bedside. But this patient, you ultimately, if they're symptomatic, you need to get, a pacemaker on them. So that's your treatment. Okay. Now, the next block, and here's your transvenous or transcutaneous pacemaker waiting for a permanent pacemaker. So that's your treatment. Um, and here's your causes. And it often progresses to this third degree AV block. And this is, so this is a little more serious than the other ones. Okay, so third degree AV block is where you have a complete heart block. Sometimes you hear it called AV dissociation, but there is basically no communication between the between the ventricles and the atria. So what happens here is that your P waves are just going to be kind of just doing their own thing, and your ventricles are going to be doing your own thing. And essentially, what happens is that you just don't have any kind of pumping function whatsoever, really. So complete heart block, occurs when this electrical impulse is completely blocked between the atria and the ventricle, and the interruption usually takes place between the AV junction and the bundle of His. And so, although these electrical impulses cause depolarization of the atria, they do nothing, and are totally blocked by the ventricle. So they are functioning independently. So how do I tell the difference between this and this? Okay, so this, you're going to see that your QRSs don't, they're not equidistant, you know. But when you have a third degree block, the P wave the R waves will march out, and your P waves will march out. And so what has happened? Well, I'm sorry, this P wave just fired right after that. But if you were to take a paper and pencil and march these out, they would march out. So so your P waves you'll have P waves, you'll have your QRS complexes as well as what appears to be PR intervals that are constantly changing in lengths. However, the PR intervals do not become progressively longer, or like they do with Winky Bach or at in Winky Bach or second degree type 1. So when you actually really look at this rhythm strip, you can see no relationship between the P waves and the QRS. And they're definitely, the ventricles and the atria are functioning independently. So when you march out these P's, they're going to all be equidistant from each other, and so are the R wave, the top of the R waves. Okay, so this is considered a life-threatening dysrhythmia because it may progress to asystole, where you have no heartbeat. And it may be lethal if the ventricular rate is so slow. So look how slow this is, and so it's like 20. There's no way that they have any kind of cardiac output or perfusion, and so it's not adequate to sustain life. And we often see third degree heart block is caused by a myocardial infarction and or severe heart disease. So we really kind of have to. This is a lethal dysrhythmia. So we're looking at absolutely. We've got to do something immediately. So if they are awake and talking to you, you know. You're going to look at, you know, of course, most likely they will be very syncopal, very, if they have severe bradycardia, I doubt they will even be, coherent a lot of times. But if they're symptomatic, we want to get this transcutaneous pacemaker on them right away until we can get this temporary venous pacemaker can be inserted. And, we'll do a lot of temporary stuff, especially atropine or epinephrine to keep the blood pressure up until we can get that pacemaker, working and a permanent pacemaker as soon as possible. So since we're talking about paced rhythms, we do what is called emergency pacing. And when we talk about transcutaneous pacing, we need, through the pads that we, deliver, impulses to pace the rhythm through the skin. And then we also have transvenous pacing, and that is when, like I said, they put an introducer into the vein, and they put some pacing wires, and they, attach them to the heart through fluoroscopy, and we pace them with this pacemaker. Now, and it's an external like little box that we use, and the box controls the rate. You can turn the rate up and down, and that will give you, the frequency that you deliver the impulse through those wires, or you can control the amplitude of how much juice you're getting every time you give you initiate an impulse through the wires, or you can turn down the sensitivity. So or up, turn the sensitivity up to see, because you don't want to override PACEM most of the time. But ultimately, we want this permanent pacemaker, and permanent pacemakers come in many shapes or forms. You can have a single chamber where it's just going to pace the atria, or will pace, both atria and ventricular. Some of them won't even be a pacemaker. They'll just have an implanted defibrillator because they go into VTAC or VFib, and so it shocks them. Um, and then, or you can have the combo, what I call the Cadillac, where you have a pacemaker with any of these functions, biventricular, dual, or single chamber, but it has the implanted defibrillator with it. So when you look at a paced rhythm, this is what you see. And so for your testing purposes, I just want you to know that this is a pacer's pipe, right? So you can see that this paced rhythm is, this is probably not a full second strip, but there's that's a heart rate of 50. And if it is, we probably need to turn the rate up to try to get them, to pace. Uh, and so you see here you have a spike, and that is initiating that, it's sending a impulse just like, your node would to the atria to say, hey, get going. So you'll see this little thing here, like a little stroke. That's where the pacemaker is sending the thing. So you'll hear there's two major modes of pacing. You have synchronous, which is on demand, and you have asynchronous. So on your pacemaker, which y'all won't probably see an external pacemaker until you go to the ICU, um, and they're going to be either on demand. That means that the pacemaker is sensitive enough to see the underlying rhythm of the patient, and so it's just going to pace when it needs it. So it's going to let those intrinsic or beats come through. And then you have a mode called asynchronous, where there's a fixed rate, and that means that it's going to pace, and, no matter what the patient's heart's doing. So temporary pacing is usually done in synchronous demand pacing mode, unless the patient requires asynchronous, where they're not making any attempt to have a heart rate or not. So like if you had somebody with any of our heart blocks, especially AV, third degree AV block, you do want the beats that are coming through to come through. And so it's going to be demand pacing. So the pacemaker sensitivity is set to sense the patient's own beats. And so when the patient's heart rate is above the set rate, the pulse generator, on the pulse generator, the pacemaker doesn't fire, it inhibits itself. And so when the patient's heart rate is less than the generator setting, then the pacemaker provides electrical impulses and it paces the patient's heart. And you'll hear some of this terminology like capture, threshold, sensitivity. We just talked about sensitivity, failure to capture, and failure to sense. So capture is actually, is it going to depolarize? Is it going to make that, you know, have enough amplitude or give enough bzz to the heart to be able to say, hey, we need to send send this electrical impulse down the heart to give me, one good complex here. And in the next one, yeah, if the heart doesn't, the settings say the rate so much, then boom, it's going to hit you with another one. Now, these aren't uncomfortable, transvenous, but it is, when you have transcutaneous, it's shocking you from the outside, so it's uncomfortable. But anyway, so your threshold is that minimum energy required, so like it's in milliamps, or it's called output on the pacemaker. And so it's the minimal amount of energy that you need to get that thing to capture is what it means. And like we talked about sensitivity, whereas it's the ability to sense the patient's own heartbeat. And so if you have a failure to capture, that's a failure to generate, a pulse. So like if you're still sending, the signal, but it's not capturing, it's not sending enough amplitude or enough, juice through those wires to the heart, then it's not gonna initiate or start the pulse down the impulse down the heart. So that may be failure to capture. Or, sometimes you have failure to pace, which I didn't put on here. Failure to pace, you just don't see nothing at all. And you got the wires on there and you're going, what, But failure to sense means the spikes fall on or near the patient's own heartbeat. So you can oversense or undersense, so you can have the sensitivity, you have a sensitivity dial just along with the amplitude that you can turn up or down that says, I'm going to be more sensitive to what the patient's heart rate is doing, or I'm going to be less sensitive, right? So for testing purposes, just be able to tell me that this pacemaker is obviously capturing sensing. It's initiating a heartbeat every time, and that's a really pretty paced rhythm. Here's another one, but this is like a dual pacemaker. See how it's pacing the atria and it's pacing the ventricle? You have two spikes here. Okay. So that's a dual pacemaker. Now, this is a picture of failure to capture. So what you see is that you see this impulse coming through, right? But then boom, boom, it's not capturing. It's not telling, it's sending the impulse, but there is no QRS that follows it. See, because it's trying to send this impulse here, because here's your actually there, this must have been a block because here's your P wave, and so this is like a block that we're trying to pace, and so it's just firing and it's not sensing. All right, and then here's another failure to capture. It looks very similar to that one. So see, it's firing, boom, it gets a nice beat, and then it fires again. So it's obviously we need to reset the pacemaker. And then this is failure to sense, and the difference between the two is that you are obviously not trying to uh, have beats here, right? You're not trying to, see back here, this is kind of regular, you're trying, you can tell you're trying to have some beats here. Okay. You're trying to set this rhythm to be a regular rhythm. Okay. But here you got pacemaker spikes all over the place. So what it's not doing is it's the pacemaker's firing without sensing that patient's inherent heart rate. So this guy right here is, obviously this is a fib, um, an AFib, it looks like to me, is the underlying rhythm, but it's not sensing anything here. It's just firing all over the place. Look at that, it's just firing here and firing here. And so basically what the patient's doing is it's doing its own thing, and he's probably fine, but the pacemaker is trying to tell him, oh, here, fire here, it's not, and it's obviously, not picking up anything. So as you see, there are pace spikes that fall on and all around the QRS complex. And with failure to capture, the pacer spikes will not be immediately followed by a QRS. So you will never see, you're not seeing any kind of QRS complex here. Same thing here. A little harder to see here, but you'll see like this little pacemaker spike here for why, because patient's own rhythm, patient's own rhythm. Um, Boom, there's the pacemaker spike. And then it's not sensing when the patient's rhythm was, because here's where the patient is having his own beat. So for your testing purposes, I'm just gonna, maybe put one up and say, and if you see these spikes, just say this is a pace rhythm. You know, failure to capture and failure to sense are something that, I'm showing you because, you may be in the unit, and if you see this going on, that's something that you won't be, not know what's happening. But for testing purposes, this is about all you're going to see. You're going to see pacemaker spikes, and you just tell me that's a pace rhythm. Okay. Now, a lot of times, um, just for your knowledge, because you'll take care of patients with permanent pacemakers. If you see a patient that it has a pacemaker, and they're going, they get admitted because they're having syncopal episodes, it's probably going to be one of these reasons. It's going to be either failure to sense or failure to capture, and so that means that they have to come in with a computer basically, and do what is called an interrogation of that pacemaker. And so they can transcutaneously, this implanted pacemaker, underneath the skin, they can talk to it through this computer. And these really, really fancy pacemakers now, they can see it from 100 miles away, and the cardiologist can say, this pacemaker needs to be, the sensitivity needs to be here, the output needs to be here. We maybe need to change it. The wires, if the wires, still an implanted pacemaker or implanted defibrillator, they still have wires, and those wires can become disconnected. If you're taking somebody care of somebody fresh post-op who's just gotten a permanent pacemaker, we keep their arm in a sling because we don't want them raising their arm up, on that side, because that can sometimes dislodge the wires, if they're not in there really good. So, those are just some things, and you have a thing on your in your book to take care of a patient with a implanted, pacemaker, fresh post-op. That is more what I'm concerned about. Do you know how to take care of that patient? And there's a nice little table in your book that talks about that. We're going to stop here. This will be the last recording, and I'll see you guys tomorrow.